Hi, this is Kelly again. I'm going to go ahead and get started. I'm here at the Center for Evidence-Based Policy in Oregon with Beth Church, who's going to help me through the process and make sure that we don't have any real technical glitches. I want to thank you for joining. I think this is going to be an important hour because we have so little time to kind of begin it, to develop an overarching model in earnest. And this gives us an opportunity to really maximize the time that we have available face-to-face in November. And so having said that, I'm just going to go ahead and get started with the purpose of the webinar today. You had asked to get a report of the status of payment reform by interviewing carriers in the state, and I'm going to take some time today to go through that at a high level, and I think the bulk of the time will be devoted to reviewing existing framework for value-based payment that's not just in alignment with Medicare, but it actually grew out of Medicare. When I sent out the slides for this yesterday, I also sent a white paper that was developed by the Health Payment Learning and Action Center that was organized and established by CMS. And so it's a very interesting white paper, and we'll talk about it more as we go through this. So these are the carriers that we interviewed: Aetna, Anthem, Cigna, Community Health Organization, I guess it was formerly Maine Community Health Organization, Harvard Pilgrim, Healthy Families, Minuteman, Tufts, and WellSense. Missing from the list is United. We've attempted to contact somebody to interview at United, and we're still trying to do that, and hopefully we will get their input too. So moving into, I wanted you to know that I found the interviews to be valuable for my knowledge base. Information that I'm sharing with my team in Oregon would be helpful for all of us out here who are leading work groups. Gives a deeper understanding of where the state is today with respect to payment reform, and I hope that the information is helpful to this work group. It's aggregated information, and also more importantly, some of the information that was shared with me was clearly proprietary and can't be repeated in this forum. So the interview questions that we asked was put together by a subgroup that included Paula, Scott Westover, and Tyler, and myself, and we asked questions specific to is value-based payment part of your payment reform strategy? How do you define value? What percentage of your contracts is in some form of value-based payment? Do you expect that to change? What's the enrollment in each of these arrangements? What's the basic nature and structure? Do they apply to all segments in your plan? How much money is at risk? How is performance measured? Are they reducing costs and in unit price or utilization? And just in general, share the results you are experienced with value-based relationships. So really there's the questions, they're big questions. They ask for a lot of information. You know, people were very willing to share information, but in a limited amount of time. We spoke for about an hour, you know, and there's a lot of detail there that isn't readily available to the interviewees. So I think we got some pretty good feedback. I'm starting with this slide. It's value-based payment is a part of all reform strategies in New Hampshire, you know, value-based payment, as discussed in these interviews, rewards increases in quality, improved efficiency and patient satisfaction. The total percentage of contracts in aggregate and value-based models, value-based payment models across the state varies from carrier to carrier. Some of the new entrants have little or none, but overall, when you think of it in terms of provider groups and their experience and their involvement in contracts that have provider-based payment models, it's well over 80%, probably getting close to 90% or so. And all carriers expect to change the number and nature over the next few years. And then so the number of enrolled members statewide, considering the markets that each carrier has, really is really very high. The number of enrolled members is very high. There is pockets with very little value-based payment at this point in time, but the efforts are continuous, and the delivery systems in these areas are organizing to be able to move forward with value-based payment. They're used across each carrier's service area, less in the north, less with new entrants, more with larger certified, NCQA certified patient-centered medical homes, and with health systems as more practices are acquired by health systems in the state. They, commonly include care coordination, per member per month fees, upside risk for quality and efficiency based on improved metrics and total cost of care for a population. It's a pretty common standard approach to it at this point in time, mostly built on a fee-for-service structure so far, with reconciliation to the cost target. Some models engage specialists. When you say pockets are geographic or something else, yeah, geographic is oh, I'm sorry. I'm sorry. I'm trying to get used to doing this. I see that I got a question that about pockets, and when I talk about pockets, I am talking about geographic pockets. So some of the models engage specialists in hospitals in some sort of an accountability for value model. That's probably way less common than simply working with the patient-centered medical homes. So risk adjustment is necessary and usually modifies the per member per month care coordination fee levels. The data and analytics support varies between carriers, and in some cases there's a very high level of data and analytics support. Providers are wary of risk, and the 90s HMO failures are still in providers' minds, and the damage really that happened at that time, is something to be avoided in the future. They talk about claims lag and variability in reporting clinical information. There are workarounds for that are very effective in some cases. ED notification, admission notification, and that sort of thing. I see I gave myself a note in here, need a word for this. I don't know what I was thinking. A lack of interoperability between EMRs is problematic. Metrics vary by carrier and practice profile. Some carriers have some standard metrics. Some actually piggyback on metrics that are being used by other carriers so as not to add reporting burden for the practices they're working with, contracting with. Meeting the providers where they are, I hear that quite a bit. Training wheels, I heard that quite a bit. So there are positive results reported on quality measures. Let's see. When value-based payment has been in place for a reporting period, utilization may be reduced. There's some strong evidence of cost of care reduction from well-developed models, but mostly it's the slowing of the trend upward. As we've talked about before, shared savings models ultimately may prove unsustainable. Payers will find it difficult to continue making shared savings payments indefinitely based on savings achieved in the past. So I wanted to just talk a little bit about some carrier model examples, and these are by necessity fairly brief descriptions. Unnamed carriers, unnamed carrier number one, rely on the PCMH NCQA tiers to determine the per member per month payment for infrastructure. But in this case, the plan employs its own care management team, including complex care managers who work with members, especially those with transplant or oncology needs, provide help with navigation, information, creative application of resources, and alternative care plans in concert with network providers. Also package this with reduce or eliminated patient cost share, waiver of deductibles in certain cases, paying the first dollar to facilitate access so that people don't go without care because they can't afford the high deductibles or patient cost share. Model number two is a care coordination fee for patient-centered medical homes. Higher targets are exceeded. Total cost of care budget built on fee-for-service with a reconciliation. Total cost of care does not include drugs or behavioral health. Use the CMS attribution model. Reward quality measures but can lose care coordination if missing the trend reduction quality measures and patient satisfaction. Plan number three offers a range of models. They have in place a range of models, some of which are pure fee-for-service. Next level is adding in quality programs, then capitation with upside risk, and then some full cap. And this plan is dabbled in bundled payments for things like routine colonoscopies, cardiac care. Fourth model, patient-centered medical home per member per month for NCQA certified level 3 only, and a minimum of 2,000 lives. They direct care to high-value providers through benefit design, and they also provide in-house care coordination and disease management. The fifth one is driving away from pay-for-performance towards global capitation of primary care. Very similar. Fee-for-service payments reconciled, also directing care to high-value settings. And finally, provider-sponsored health plan, integrated systems partnering with existing plan to assume 100% of risk for a population, and they employ a variety of strategies to achieve AAA. So that's the models that I wanted to point out. Would like to have more detail to present, but it just didn't work out that way. And I think that the next slide will begin to describe some of the takeaways that I got from the interviews. Obviously, a high degree of alignment with Medicare models and Medicare approach. Feedback that the models in place shouldn't be disbanded, but continue on the path with strategies to accelerate change in sync with Medicare innovations and timelines. Given the existing variability in metrics reported, a single set unilaterally may not be realistic, achievable. Care coordination professionals should be better prepared and engaged. Often physicians in a practice are not well informed about the value-based model or understand the incentive. Some of the hospital systems that are employing physicians of acquired medical groups are reluctant to invest in the NCQA certification process. Some of these systems don't have an effective process to reward employed physicians for cost and quality improvements because they that they don't get passed through in a way that's meaningful. I think it would be great if we had more robust reporting on what the state of transformation is today in New Hampshire, but at this point I don't feel a strong need to do more research down this path, and I think we need to focus our limited time on the future model design. So moving on to the next phase of this webinar, I'm going to talk about a value-based payment framework, beginning with the goals that we hit them briefly, I think, in our last meeting, October meeting.
Sorry, hey, Kelly,
Yeah.
it's Lucy. Do you want to just make sure we don't have any, if anybody has any questions, are they just sending them right to you about that portion? Because we're sort of done talking now about the information we gathered from the interviews, right?
Yeah, thank you, Lucy. I'm glad you pointed that out. I'm not getting any messages in the chat box, so this is the right opportunity to talk about the carrier interviews, and feel free, any of you, to speak up if you have questions or you want to make comments. You think I missed out on something important, and go ahead.
Guess, Kelly, this is Henry Lippman. Feel a little bit in terms of trying to where to take this at the end, maybe need to let you go a little bit further, but sort of how to assimilate it into the work product that we're trying to deliver, I guess, is ultimately my question on this.
Okay. Yeah, and that's the perfect question. And when we get to the end of this, either during or to the end of this next segment, then we have to have that conversation: is how to assimilate it, and where to go from here, and how to get where we're going in the short period of time we have left.
And I think Kelly, you did a great job sort of summarizing. I think, Henry, to that point, some of the key takeaways were certainly the commercial payers are tracking the Medicare alternative payment incentive type programs. You know, they don't want to stray wildly from that type of situation. That right. EMR compatibility and data compatibility is always an issue, and that, you know, they're not, that oftentimes incentives don't get passed down to those who need to be incentivized. It's a little bit of what I do.
So in that direction, you know, I think that Medicare-like is the right direction. I guess the issue from the provider perspective is that Medicare-like is that there's, you know, 30 flavors of Medicare-like and relatively small populations in each. And I also recognize the comment that people don't want to, you know, be forced to get off existing contracts, but it sort of is a long-term strategy. It's sort of like in the quality arena that, you know, coming up with some common metrics and approaches that somewhat standardize it, not saying that everybody has to be on a primary care or what have you, but if you're in a primary care model or a medical home model, you know, there's these shades of gray, as opposed to, I think, when you've seen one Medicare-like one, you've seen one Medicare-like one, and that's, I guess, the issue that I see out there. And in terms of trying to deliver incentives back, is, you know, having, you know, population levels in a practice or in a situation where there's, you know, statistical significance about what the variations might be. I think those are some of the challenges at operationalizing some of this stuff.
Yes. Yes. Any other comments? Okay, so in front of you, you see the goals, pretty aggressive. 30% of Medicare payments are tied to quality through alternative payment models by the end of 2016. And in parentheses there, it says categories 3 and 4. and we'll address that in just a minute. And then 50% by the end of 2018. And then second goal, 85% of fee-for-service payments tied to quality categories 2 to 4 by the end of 2016, and 90% by 2018. Let's go to the next slide. So this is how CMS identifies the APM framework. Category 1, fee-for-service, no link to quality. Category 2, fee-for-service, link to quality. Category 3, all APMs built on the fee-for-service architecture. And then Category 4, population-based payment. Did we miss one? I think we might miss one there. Oh, you got it? Oh, okay, yeah. Healthcare Payment Learning and Action Plan. So this, I'll just read this to start with. It established the plan to provide a forum for public-private partnerships to help the U.S. healthcare payment system meet or exceed Medicare goals for the value-based payments and alternative payment models. Network will serve as a forum where payers, providers, employers, purchasers, states, consumer groups, individual consumers, and others can discuss, track, and share best practices on how to transition towards alternative payment models that emphasize value. Now, I don't know if you all are familiar with the Healthcare Payment Learning and Action Plan, and I was familiar with it, but I didn't know what it really was until week before last, when I was sent a white paper that they developed. And I attached that white paper to the email I sent out yesterday evening with the slides. And so you should all have it, except for, I think, two of you couldn't receive it because it was too large. So I'll make sure that I send it again and make sure everybody has it. I think there's a great deal of really good information in it that can help inform our work going forward. The next slide. So Workgroup strongly maintains shifting from traditional fee-for-service to population-based payments will be essential to sustain delivery systems with the value, quality, cost-effectiveness, and patient engagement. Because the ultimate objective is to achieve patient-centered care, the Workgroup believes it is absolutely essential to monitor the impact of population-based payment systems on patient outcomes, healthcare costs, and other indicators of significance to patients and other stakeholders in the healthcare system. Workgroup envisions the shift to population-based payment as a course-correcting feedback loop between innovation, implementation, and evaluation. And I want to emphasize the course-correcting feedback loop of this slide. One of the work groups that the HCPLAN has established is in the process of developing an approach for measuring alternative payment method adoption across the U.S. healthcare system. And that tool, if it gets developed on a timely basis, I think would possibly be something that would work as a model for us going forward. So the HCPLAN modified the CMS alternative payment model framework in the way that is described on this slide. Builds on the framework, uses the same 4 categories as the foundation. In the white paper, they talk about key principles that guide them. They have introduced 4 new categories to account for models that are not considered progress towards payment reform. They introduced 7 categories to account for nuanced distinctions between the 4 categories that CMS has in their framework. Delineates decision rules to place alternative payment methods in a subcategory, and compiles examples of alternative payment models to illustrate key characteristics of each of the subcategories. Now, this is all in the white paper and was presented in a Learning and Action Summit on October 26th. And the presentations from that summit are fairly extensive. It was a 2-day Summit, and they're found on the HCPLAN Summit website for anybody who is interested in going there and seeing some of those presentations. So this next section describes the APM framework that came out of the Learning Action Plan. Category 1 is the fee-for-service model based on volume of services not linked to quality. Category 2 then starts to add in features, value features. Category 2A, payment for infrastructure and operations to improve care delivery such as HIT, telehealth, and care coordination fees. So, that's happening. I don't really know I didn't really get the size of these payments. I know that that's proprietary, but I do know that some are low and some are relatively high. None of them sort of rise to the level of the CPCI payments that Medicare CPCI demonstration, which started with a $20 PMPM payment for the first couple of years to the participating groups, and then was reduced to $15 PMPM. So category 2B, pay for reporting and rewards for performance, bonus payments for reporting or quality performance, DRGs in the case of hospitals that reward reporting or quality performance, and fee-for-service rewards for reporting or quality performance. Category 2C, the rewards are bonus payments for quality performance, DRGs with rewards for quality performance, and fee-for-service with rewards for quality and performance. D subgroup is rewards and penalties for performance. Bonus payments and penalties for quality performance, DRGs with rewards and penalties for quality performance, fee-for-service with rewards and penalties. So D is where we start into downside risk, I guess. Category 3, alternative payment methods with upside risk, bundled payments with upside risk, ACOs with upside risk only, patient-centered medical homes with upside risk only, centers of excellence with upside risk only. And I think to some extent that's where we are now in the state, or knocking on that door. Then level B, we're trending towards level B, which is bundled with upside and downside risk. I didn't see much evidence of that happening in my conversations, but ACOs with upside and downside risk, PCMHs with upside and downside risk, centers of excellence with upside and downside risk. Now, I do know there's some downside risk in some of these models in the state. I don't believe that there's a lot of downside risk at this point in time as a percentage of the total volume of payments. And then category 4, which is the top category in terms of payment transformation, limited population-based payments. Population payments for specialty, condition, and facility-specific care, partial population-based payments, global budget for hospitals linked to quality, and B, comprehensive population-based payments, full or percent of premium population-based payment linked to quality, global budget based on population, and served linked to quality. So that's a description of the HCPLAN categories. And so having seen that and having an opportunity at some point to review the white paper, I think that we should think about this in terms of, to what extent can we tie the work that we have to do, the model that we have to design, to what CMS is doing to support payment transformation. And the more we tie to Medicare, the more support we can expect from Medicare going forward in a variety of ways. And I'd like to have, we have time for a discussion here in the webinar, and I'd like to also hear via email if somebody wants to have make comments via email after the webinar, or if any of you want to have a one-on-one discussion with me, I would deeply appreciate that opportunity to talk to you individually about your views. We're going to, we being Lucy, Doris Lotz, and I are going to have a planning meeting early next week, hopefully early part of next week, early to mid next week, planning for the November 18th meeting. And so if you have an interest in having a conversation one-on-one with either me or Lucy and I, if you could let me know after the webinar, then I'll get on your calendar, and hopefully your input will help us plan the November 18th meeting. So at this point, I would just simply like to ask for your feedback. If you have feedback, if you have advice, or if you have questions about some of then we could address those. I see I have a message here. Could you help me with that? That's it. I'll scroll up. Okay. I'm concerned that Medicare attribution in some models does not include APRNs, and they do not allow incentives directly to providers. So I will just make note of that. I don't know how to respond to it at this point in time, but thank you for that.
Kelly, this is Jean Ryer.
Hi, Jean.
It seems to me that we're trying to build a new road here, a new highway, and people are going to be, or perhaps extend an existing one, and people are going to be entering it at different points.
Yes.
And how do we design this in such a way? Because I'm just, mentally scanning the universe of providers that I know about, and they're all along this continuum.
Exactly right.
So how do we do that? And is there any, I didn't get to read the white paper. Is there any guidance in there about it?
Yeah, so I agree with you, and that's, I think, why I like the framework, or some version of the framework, because when you do scan the state, there is a great variability as to where provider groups are with respect to payment transformation. And so the framework gives you the opportunity to see where you are on the spectrum and where you should go. And also, hopefully, we'll have, if this model for tracking is developed, or we can develop our own model for tracking, we can track that over time. A big part, in fact, maybe actually the key piece of the SIM process is demonstrating and testing. So if we were to adopt as a state a framework that showed the pathway to population health payments, comprehensive population health payments, and then we tracked our progress along this as we climb this framework, you don't all have to start in the same place. That's you start where you are, and then you begin to understand what it takes to move to the next piece. So when you think about the approach, the final model will actually have to identify what really drives this change. This is a framework. This doesn't really drive change. It just tracks change, and it identifies, it defines what it means to reform payment. But there have to be other pieces of the model that really will drive. Part of that is practice transformation work. Part of it is really what this whole overall governance structure will look like when it's defined. And so we're kind of at a cusp here. It's really time to understand as deeply as we can what the straw person framework or the straw person overarching model, including all the various pieces, will look like. And then you begin to understand more how a framework like this, I think, fits in and supports that and just helps with understanding. And that's kind of a random answer, Jean, but does that make sense?
Yeah, I want to sort of make my broken record statement again at this point. So, and that's my really firm view that practice transformation and payment reform have to be very closely linked, so that that there are the resources in the payment reform in order to support practices in continuous improvement processes in practice transformation. They're not going to transform once. This is a continuous improvement process. And
right.
So those two functions, I mean, all of these functions fit really closely together, but those two functions have to be built into each other so that there's financial support for the practice transformation, and that the practice transformation is indeed supporting the payment reform.
Right. So you don't do practice transformation to match some payment model. You do payment models to support practice transformation and allows it to achieve the goals of transformation.
But it also has to, yes, but it's got to provide enough money up front to support that to allow that transformation to take place. So the reality on the ground at this point is that absent life in some big systems, providers, especially at the primary care and specialty level, do not have the financial or human resources to put towards practice transformation, or time, because the reimbursement demands on them that are present. You know, they will lose revenue, and patients will not have access to care for the time that they're spending on practice transformation. So we have to solve that conundrum.
So Jean, it sounds like you're saying that the devil is in the details, that it's really drilling down to make sure models, implementation, outreach, and expertise are available to the practices as they work through which one of the models or how to move forward.
I think, Lucy, I'm actually saying something a little bit beyond that. So yes, they need to have access to all of these resources, but they also, and I think I asked Sharon about this. I'm not sure how the advanced payment ACO worked out, but front-loading some money for transformation might not be a bad idea.
Right. So I think that needs to be on the table. And as you point out, some practices need a lot more resources than others. And I'm just going to assume that, and I may be wrong, but I'm assuming that the practices that are actually owned by hospital systems are financially better prepared to make changes.
I would not assume that, Kelly, at all. I think
okay.
some systems are, and other systems. Henry, I guess I'd ask you that question. I don't think it's a good statement.
I think there's a lot of variability based on some factors or size, location, and some of it doesn't necessarily correlate with that either, you know. But you know, the bigger your population and the better your commercial population, the more likely you are to be able to do things, but there's still exceptions to that. You know, I'm thinking about what we're talking about here. One of the things I don't know if this is bouncing off the track too much, but maybe what we really should be striving for is a set of principles that are long-lasting and evolutionary as the market of how practices and organizations are organized, you know, continues to mutate, if you will. And you know, I think that if we could take something that's instructive from the Medicare policy, which is, you know, they're suggesting in order to you know, not receive penalties or to receive incentives, if you will, a certain percentage of your work has to be in the certain zone of practice of payment model reform. And, maybe what we ought to be aiming for is something more like that, as opposed to being, trying to come up with, specific models. I think the principles that are sort of underlying the stuff that we've talked about. I'll just stop there and get your reaction to that.
Well, my reaction is yes, and how would we go about developing those principles?
Well, I think, one principle is that from the payer side, you want Medicare-like stuff, right?
Yeah.
And from the provider side, you want participation-like stuff under sort of Medicare, right? And then you could develop sort of different principles based on the level of risk. So if it's a upside only kind of arrangement, the principles look like X, Y, and Z. And if it's a downside risk, with corridors or unlimited, you're gonna have different set of principles. So for example, attribution is really important when you're taking significant downside risk. Not as critical if you're in a different model of a gain sharing. It's helpful, of course, but it's not putting you at financial instability should you miss it.
Yeah.
So I think there are certain elements based on the risk and the quality metrics that are built into it.
Yeah. I'd like to try and pursue that. I wonder if we could talk offline or
Sure.
or something of that nature. If you've got something, a direction you want to point me in to do some research, that'd be fine. But I'd really like to have a conversation with you, Henry, to kind of make sure I understand completely what you're talking about and how I would approach bringing something in front of the group, to react to.
Sure. I mean, to be honest, this sort of struck me as I was listening to the conversation and listening to your presentation that if we get too prescriptive on the model, we're going to have, I think, some challenge both directionally with payers and providers. Whereas I think if we, are coaching to a set of principles and requiring, a level of participation, I think we're more aligned with where Medicare is trying to take everything, and it's probably, more likely to be doable in the small and rural markets where Medicare drives a lot of the policy, and Medicaid for that matter.
Yeah, okay.
Hey, Kelly, can you talk a little bit at all about where the white paper goes, or how we can explore partnerships with non-medical providers or other service providers in the medical neighborhood as part of this?
Okay, so I would actually refer you to the white paper only because it's fairly extensive, and I don't have a complete grasp of everything in it. But the medical neighborhoods are addressed in not using that medical neighborhood language, but they're addressed less directly in the categories, the level 3 and level 4 categories, which in the case of more sophisticated and developed care coordination activities that allows the team approach to care that pulls in the specialists and the hospitals and really works towards care plans and alternative care plans for patients with a patient-centered approach to really trying to understand as a team how we get the patient to their best health. And so so that's kind of something I can probably flesh out for you in some specific language, but that's kind of how I see it.
Yeah, I'm just really, I'm digging too deep. I haven't seen, real examples of how to incorporate that into an incentive structure.
Okay. All right. Yeah.
Doris is always talking about, the why, or
Yeah.
is
Does anybody
it
else?
just a relationship, or is it more than that?
Okay. Let me see if I can look into this a little more and give you some sort of an answer to what that would look like to put some sort of a priority on extending what's already happening at one level into the whole entire medical neighborhood approach to it. And some of you on the call may have some perspective on that. But if you want to have a conversation after this during the next few days, please let me know, and I'll just adapt to whatever your schedules are. So any other comments at this point? I did want to respond to something Jean said a little bit about the resources available. And just so you know, Jean, we've had that same conversation with other states we work in. And, that's a business decision for the carrier to decide, how much they're willing to fund these activities that are non-encounterable, non-reimbursable, to make the changes that are required for true medical home success. And, what we know from a variety of resources is, and I think I mentioned this earlier, it varies a lot. And so I think as part of our overarching design, that has to be addressed in some fashion, and we can't we can't really control the investment from a carrier to a patient-centered medical home, but there can be another approach to funding that will be available through the regional health care extensions or whatever those ultimately are titled, to have some money available to help sustain practices that are in the process of making those kinds of changes in order to provide, the triple aim to their patients. So that definitely is on the table and has to be addressed in some way.
Thanks, Kelly.
Sure. So, Lucy, anything else from you?
No, Kelly, thanks. That was very helpful. And I think if people have questions about any of the details, Kelly has it all packed from a lot of interviews that were, and Paula, thank you, and Tyler for helping put that questionnaire together. I think it was a useful exercise.
I just would encourage you to take a little time and read the white paper and on your own. And so I think it's a really it's a guide for me. I think it informs the direction in a sense, not as a final model, but as a path to understanding where we are in transformation. At least inside there. There's also in the white paper there are examples from across the country of different payment models and where they fit into this framework. For example, the Anthem enhanced personal care model is there, and it's defined as I think a level 3A or something of that nature. Cigna also has their CAC model in that white paper, and it's defined at some level of one of the categories. I don't remember what it is offhand, but
Hey, Kelly, it's Lucy. One more thing. If people haven't checked the website is a little bit difficult. You have to go up to the bars in the top left corner to get the pull-down menu and find the various sections. But if you weren't able to get on the calls summarizing where the other work groups are, there's some pretty helpful information on the website. But Kelly, maybe we can circulate at least the practice transformation, the latest and greatest from them before our next meeting would be great.
You want me to circulate it directly, or that it's?
Yeah, I think that would be helpful. I think that's easier for everybody.
Okay, I will do that. And go ahead. Is that Henry?
Before we hang up, I was just interested in Tyler's perspective, if you would mind sharing it on sort of an organizing principles approach based on kind of the work you're trying to do to facilitate the market's functioning, for both from a provider and consumer standpoint. If you're still on.
I think Tyler dropped off about 10 minutes ago.
Okay, sorry.
I'm going to check in with Tyler, Henry.
Yeah. I mean, I guess, Lucy, from where the governor might want to take this, I mean, don't you think that might be an easier way to actually gain some traction that would be more policy in nature than
a prescriptive approach? Yes, I absolutely do, and I think it's sort of a place we all started at and are coming back around to. I think Henry, in fact, your comment at the very beginning was everybody's at sort of a different space and state, right, coming in at meeting them where they are based on their regional diversity and practice development and consolidation evolution is critically important. So I agree with you, and I'm looking forward to hearing what Tyler has to say.
Okay.
And I also think, based on what we heard at our symposium as well earlier this week, is that there still is not a level of penetration of alternative payment structures in any one of our markets, Medicaid, Medicare, or commercial, that meets everybody's goals. So it obviously, in allowing for flexibility, will help move everyone a little bit further along the spectrum.
Right, and with some set of principles, you might be able to set the expectations as to what the next level you might be able to move to.
Right.
But the fact that there'll be some incentive to participate in something is, I think, something that you can't sit on the sidelines, so to speak, if you want to participate in say the state's programs. You've got
right. And it's also not inconsistent with sort of the direction that everyone developed through the 1115 transformation waiver, which was,
sure. Yep.
Developing from the ground up with support from top down.
Right. Okay. Kelly, if you wanted to catch up after the webinar here, I have a few more minutes this afternoon, or if you want to do it another time, that's great too.
I can call you, Henry, and just as soon as we're done here, I'll give you a call.
Great.
Thank you.
Thanks, everybody.
Thank you very much.
Thanks, Kelly.